Good morning. I'm Dr. Donna McNamara, and I specialize in women's oncology at the John Thayer Cancer Center at the Hackensack and Mountainside locations. Today, I'm going to discuss the nemesis of all breast cancer diagnoses, triple-negative breast cancer. Let's start with the basics. I'm sure we're all aware that breast cancer is the most commonly diagnosed cancer in women, with 1 in 8 women diagnosed during their lifetime. It is the second leading cause of cancer death among women behind lung cancer, and each year over 280,000 women in the US will be diagnosed with breast cancer, and greater than 40,000 women will die of their disease. Although we typically associate breast cancer primarily with women, men can develop breast cancer as well. Approximately 2,600 yearly, and about 530 will die of their disease. Breast cancer does not know geographic boundaries. It is the most frequent cause of cancer among women, not only in the US, but worldwide. In fact, across the globe, a case of breast cancer is diagnosed every 19 seconds, and a woman dies from breast cancer every 60 seconds. The number of cases is expected to continue to rise, and at this rate, another 13 million people around the world will die of breast cancer over the course of the next 25 years. The good news is that women with breast cancer live, and the survival rates continue to increase over time. This is due to earlier detection, better therapies, enhanced supportive care, targeted therapies, tailored therapies, and novel therapies. So this is breast cancer 101. The breast is essentially a milk machine. Milk is formed towards the back of the breast in what we call lobules, and the milk is transported out towards nipple to feed baby via a network of ducts. And 95% of breast cancer is formed within this breast duct system. If you take a normal duct and cut it in cross-section, you should see an empty pipe consisting of a single layer of normal breast ductal cells. What can sometimes happen, however, is that these cells start to multiply and fill in the duct. These aren't cancer cells, however, there's something abnormal or atypical about it. So we call this atypical ductal hyperplasia just meaning too much growth. What can then happen is that these already abnormal cells mutate, which is what cancer is, the mutation of what used to be a normal cell. These cells turn into cancer cells that can multiply, but don't have the ability to travel, commonly known as a pre-invasive cancer, an in-site cancer, ductal carcinoma in situ, commonly referred to as DCIS. However, another mutation can occur, giving these cells the ability to escape or invade outside the duct. These are the cells that have the potential ability to enter the bloodstream, spread throughout the body, or invade the lymphatic system that leads to the lymph nodes, invasive ductal carcinoma. It is important to realize that not all breast cancer is the same, and different subtypes are treated differently. There's hormonally receptive cancer, which is the most common, comprising about 65% of cases, HER2-positive cancer, a more aggressive subtype comprising about 20% of cases, and then there's triple-negative breast cancer, consisting of about 10 to 15 cases of all breast cancer. In terms of prognosis, best case scenario, we have an invasive cancer that is positive for the estrogen and progesterone receptors, but negative for HER2. Not as good, but not terrible, is triple positive breast cancer with all 3 targets available. Less good is when we have no estrogen or progesterone, but only the HER2. Worst case scenario is the subgroup without any targets, the ER negative, PR negative, HER2 negative, better known as triple negative breast cancer subgroup. This subgroup of breast cancer has the worst prognosis. Why is that? What makes the triple negative subset so difficult to treat? Let's further define the targets. For ER and PR, there exist very potent anti-hormonal therapies. For HER2 cancers, we also have increasingly effective targeted agents. Triple-negative breast cancers, however, have no targets to focus on, making them more difficult to treat. So let's focus on triple-negative breast cancer. It comprises 15% of breast cancers worldwide, about 200,000 cases per year. There's a higher incidence in younger women under age 40, as well as in African Americans. Up to 20% of patients may harbor the BRCA mutations, and survival for patients with stage 4 metastatic disease at 5 years is an abysmal 12%. For simplistic staging of breast cancer, stage 1 through 3 is confined to the breast and axilla, referring to the lymph nodes under the arm. Spread beyond these locations is considered metastatic or stage 4 disease. Today, we will mostly be concentrating on the treatment of stage 4 disease. I always point out this graph to my patients. Patterns of distant recurrence for triple-negative breast cancer are distinct. In women with triple-negative breast cancer, the recurrence rates rise rapidly within the first 2 years after diagnosis, with a rapid decrease after year number 3. Those with no evidence of progression or recurrence after 8 years were unlikely to experience disease recurrence. Let's dive into the treatment of triple-negative breast cancer. We'll talk about what we've been doing till now, what new treatments are now available, and what's coming in the not too far future. Starting with what's old, standard chemotherapy. Not to age myself, but if anyone remembers My Big Fat Greek Wedding and all words having a Greek origin, this actually works here because kaitos is a Greek word meaning container or cell. Cytotoxic chemotherapy, our traditional chemotherapy, kills rapidly dividing cells. Although cancer cells, especially in triple-negative breast cancer, divide rapidly, so do many normal cells, such as the hair follicles, the bone marrow, and the lining of the gut. Thus, we see the many side effects of conventional chemotherapy. Until as recently as 2018, we have solely relied on cytotoxic agents with only modest success. We typically use single-agent chemotherapies to preserve quality of life, and also due to the fact that sometimes dual agents increase initial response rate, but unfortunately do not help patients live longer. Most chemotherapies are effective for a duration of only 3 months in this disease. Patients with metastatic triple-negative breast cancer treated with conventional chemotherapies have a median survival of only 12 to 18 months and an estimated 5-year overall survival of only 11 to 12%, as we mentioned before. Thus, therapeutic innovation for early and late triple-negative breast cancer has been desperately needed. Fortunately, there have been several recent advances in triple-negative breast cancer. Immunotherapy, antibody drug conjugates, and PARP inhibitors, and we'll discuss all three. Starting with immunotherapy. In immunotherapy, there are some terms that you should be familiar with that will be used in this presentation. To start with some background, immunotherapy is a type of cancer treatment that helps the body's immune system fight cancer. The immune system naturally helps your body fight infections as well as other diseases. It's made up of white blood cells or immune cells, such as T cells, that detect and destroy abnormal cells and can also prevent or curb the growth of many cancers. Immune cells are sometimes found in and around tumors. These cells, called tumor infiltrating lymphocytes, or TILs, are a sign that the immune system is responding to the tumor. People whose tumors contain TILs often do better than people whose tumors don't contain them. PD-1, which stands for programmed cell death, is a protein found on the surface of T cells that, when triggered, essentially shuts off the immune system. PD-L1 is a protein found on the surface of cancer cells that attaches to PD-L for the purpose of shutting down the immune system and escaping detection. The TMB, tumor mutational burden, refers to the total number of mutations or changes found in the DNA of cancer cells. Knowing the tumor mutational burden may help plan the best treatment. For example, tumors that have a high number of mutations appear to be more likely to respond to certain types of immunotherapy. And finally, the combined positive score. This is calculated by measuring the quantity of PD-L and PD-L1 found in tumor cells, as well as the infiltrating lymphocytes. A combined positive score of greater than 10 can predict response to some immunotherapy agents. This is my rendition of how immunotherapy works. The immune system can usually recognize and kill cancer cells. Some cancer cells, however, have the ability to turn off the immune system through a mechanism called PD-L, PD-L1. Basically, the T cell has a protein receptor called PD-1, which has the ability to attack and kill bad cells such as cancer cells. Some smart cancer cells, however, can learn to deactivate this immune response with a counterprotein called PD-L1. This turns the immune system off, allowing the cancer cell to survive. Until now, This is my rendition of how immunotherapy works. The immune system can usually recognize and kill cancer cells. Some cancer cells, however, have the ability to turn off the immune system through a mechanism called PD-L1. Basically, the T cell has a protein receptor called PD-1, which has the ability to attack and kill bad cells, such as cancer cells. Some smart cancer cells, however, can learn how to deactivate this immune response with a counterprotein called PD-L1. This turns the immune system off, allowing the cancer cell to survive. Until now, we have uncovered the antidote, immunotherapy. Immunotherapy is able to block PD-L1 from neutralizing PD-L, enabling the immune system to reactivate against the cancer. There are two approved agents in triple-negative breast cancer for immunotherapy, atezolizumab, known as Tecentriq, and pembrolizumab, known as Keytruda. Trials have been performed evaluating both of these agents in triple-negative breast cancer, and they have both been proven effective. One lesson we have learned is that earlier treatment with immunotherapy is better with increased response rates. Here we see that with both atezo and pembro, a significantly increased response rate when immunotherapy is used in the first-line setting as opposed to the second line or greater. We see from these graphs that for immunotherapy, the responses are durable for up to 2 years, which is remarkable for this subtype of disease. Studies have also been performed combining immunotherapy with chemotherapy. Impassion 130 was a trial evaluating a chemotherapy drug, nab-paclitaxel, plus atezolizumab versus placebo. The impressive overall survival in the PD-L1 subset was 25 months versus 18, a 7-month difference. Yet, atezo is a pass-fail agent. Although initially granted accelerated approval in 2019 based on that unprecedented 7-month overall survival benefit, this could not be reproduced on the confirmation study in Impassion 131. This looked at Taxol with atezo versus placebo. Genentech voluntarily withdrew atezolizumab for the indication of metastatic triple-negative breast cancer in August of this year. Pembrolizumab has a happier story. In the Keynote 355 study, 847 patients with inoperable or metastatic triple-negative breast cancer were randomly assigned to chemotherapy with or without pembro. This trial also evaluated responses for patients with a combined positive score greater than 1 versus greater than 10. Overall, there was a modest improvement in progression-free survival with the addition of pembrolizumab, 7.5 versus 5.6 months. When stratifying by combined positive score, however, patients with a CPS greater than 10 did significantly better with a 9.7-month disease-free survival compared to 5.6. Pembro was FDA approved in November of 2020 for first-line therapy in PD-L1 positive advanced triple-negative breast cancer with a combined positive score of greater than 10. More recently, on July 26, 2021, the FDA approved pembrolizumab for high-risk early-stage triple-negative breast cancer in the curative setting in combination with chemotherapy as a pre-surgical, what we call neoadjuvant treatment, and continued after surgery for 1 full year. Although these drugs are not chemotherapy, they can still have side effects. Because the immune system is now charged to fight, the heightened immune response may begin to attack healthy tissue, causing autoimmune effects that can affect a variety of organs. The most commonly affected organs are the skin, presenting as a rash, or sometimes the colon, presenting as diarrhea, which can become very severe. Other organs include the pituitary gland, thyroid, lungs, heart, kidney, liver, and muscle. Another new and exciting category of anti-cancer drug are the antibody drug conjugates, or ADCs. ADCs are composed of a monoclonal antibody, which is attached by a linker to chemotherapy. The antibodies target specific proteins on the surface of cancer cells. In triple-negative breast cancer, many cells express a protein called TROP2. A monoclonal antibody targeting TROP2 has been designed and developed, carrying a mother load of chemotherapy programmed to detonate within the cell. Here's how it works. First, the antibody selectively binds to TROP2 protein found on the surface of the tumor. Next, the antibody drug complex is internalized into the cell. Lysosomes, which contain digestive enzymes, degrade the conjugate and lead to the release of the cytotoxic payload, leading to cancer cell death. simple and elegant. Because these ADCs are so targeted to the cancer cell, they maximize cancer kill while sparing most normal cells. Sacituzumab govitecan is an antibody-drug conjugate targeting TROP2 that has been evaluated in heavily pretreated triple-negative breast cancer with impressive results. The ASCENT trial was a phase 3 randomized trial comparing sacituzumab govitecan to chemotherapy of a physician's choice. Patients had to have received at least 2 prior lines of chemotherapy, and here are the results. As you can all see, the response rate to any of the chosen chemotherapy agents was pretty abysmal. However, the average time to progression, overall survival, and overall response rate were significantly better with sacituzumab than with single-agent chemotherapy. Myelosuppression and diarrhea were more frequent with sacituzumab. Also of note in the ASCENT trial, there was an overall survival benefit for all patients, regardless of age. Patients under 65, median overall survival of 11.2 months versus 6.6 months with only chemotherapy. And for patients over 65 years, the median overall survival was 15.3 months versus 8.2 months. We can also see the improved overall response rate, clinical benefit rate, as well as the median duration of response, all significantly improved with the use of sacituzumab in both age groups. On the ASCENT trial, side effects were tolerable, with only 4.7% of patients stopping treatment with sacituzumab due to adverse side effects, compared to 5.4% of patients stopping due to side effects from chemotherapy. Myelosuppression and diarrhea were more frequent with sacituzumab, and hair loss can unfortunately occur. The clinical benefit of sacituzumab confirmed the use of this agent as standard therapy for patients with pretreated metastatic triple-negative breast cancer, and Trodelvy was FDA approved for use in metastatic triple-negative breast cancer in April of this year. And finally, onto the PARP inhibitors. Just some quick background on hereditary breast cancer. 5 to 10% of breast cancer is hereditary due to the BRCA1 or BRCA2 genes. Who should be tested for hereditary breast cancer? These are some of the red flags. 3 first-degree relatives with breast or ovarian cancer. 3 generations of breast or ovarian cancer. Breast or ovarian cancer diagnosed prior to the age of 50. Male breast cancer, bilateral breast cancer, Ashkenazi Jewish heritage, and breast cancer that is triple negative. So what does genetic testing involve? Genetic testing examines a person's DNA, typically using a blood sample or a buccal swab, looking for mutations that could be harmful. It's important to realize that not all mutations are harmful. Some may be normal variants that don't alter the function of the gene. Others, however, can lead to health issues such as cystic fibrosis, blood disorders, or cancer. As previously mentioned, the 2 major mutations that we worry about are the BRCA genes, BRCA1 and BRCA2. Every time a cell divides, it has to make a copy of its DNA. Any mistake made in that copying process could lead to a mutation. Have the right mutation in the wrong place, and this could lead to cancer. The function of the BRCA genes is to correct mistakes in DNA, thus preventing cancer from developing. Mutations in the BRCA genes can lead to an increased lifetime risk of breast cancer 60 to 80%. In regards to testing, we can check for only the gene in question. However, more often, we're now using panels to check for the BRCA genes as well as a number of other genes, many of which have been newly discovered. So what are PARP inhibitors and how do they work? The wonderful thing about Mother Nature is that she always has a backup plan, so that if one process fails, another is available to take its place. And that's essentially the purpose of the PARP, poly-ADP ribose polymerase inhibitors. Both BRCA1 and BRCA2, as well as PARP, function to repair DNA damage within a cell. This allows a cell to grow in a healthy way because too much DNA damage leads to cell death. If BRCA1 or 2 is damaged or not working, the cell is dependent only on PARP for all DNA repair. In cancer cells, we can take advantage of this process, PARP inhibitors. They prevent DNA repair in cancer cells, and without the ability to repair DNA, the cancer cell dies. The 2 PARP inhibitors that have been studied in breast cancer are olaparib, brand name Lynparza, and tilazaparib, brand name Talzenna. Olaparib was studied on the Olympiad trial, which included patients with BRCA1 or BRCA2 mutations were negative for HER2, but could either be ER positive or ER negative, with predetermined plans to look at each subgroup. Patients were randomly assigned to either the olaparib or the chemotherapy arm. The results were significant for improved disease-free survival 7 months compared to 4.2 months, with a 42% risk reduction of disease progression or death. Based on these results, the FDA approved olaparib for use in patients with BRCA-mutated metastatic breast cancer in January of 2018. Talazoparib was evaluated in the Embraca trial. Similar to Olympiad, patients with metastatic breast cancer, BRCA mutated, and HER2 negative were enrolled and randomly assigned to receive either talazoparib or physician's choice of chemotherapy. Results revealed that patients on the talazoparib arm had statistically lower progression-free survival, 9 months versus 6 months, and based on this data, talazoparib was FDA approved for use in metastatic breast cancer, BRCA mutated, HER2 negative in October of 2018. So what's next? Those are the exciting new treatments in triple-negative breast cancer, but we're always looking for new novel therapies. So what's next? Genomics. As we've noted, cancer is a mutation of what used to be a normal cell. Therefore, your cancer cell genes are different than your normal cell genes. That was too quick. Genomics. As we have noted, cancer is a mutation of what used to be a normal cell. Therefore, your cancer cell genes are different than your normal cell genes. And this can potentially be exploited. Scientists have developed a method by which we can better analyze cancer cells and look for weaknesses, hoping to find the cancer cell's Achilles heel and target it. For genomic testing, a piece of tumor is sent for analysis. Gene sequencing is performed, looking for mutations, and the data is reported. Some mutations, such as BRCA, we can target with currently available agents. For other mutations, however, drugs may be under development or possibly available via clinical trial. And this technology continues to advance. Many of my patients ask me why their cancer stops responding to therapy, and the answer is in tumor heterogeneity. Again, cancer cells are mutations, and they continue to mutate. Within one tumor, therefore, you can have multiple populations of cells, all slightly different. When we give anti-cancer treatment, we're able to eradicate several of these populations. However, there can be a population of cancer cells that's resistant to treatment and survives. Darwinism at its greatest. These newer mutations won't be seen on the original tumor because they hadn't occurred yet. Which led to the development of the liquid biopsy. When cancer cells die, their genetic material is released into the bloodstream. Technology now exists to take a blood sample and separate cancer DNA from normal DNA. And this cancer DNA could be from any population of cancer cells existing within the body. In this way, we'll be able to truly hone in on these new mutations in real time, which led to the development of the liquid biopsy. When cancer cells die, their genetic material is released into the bloodstream. Technology now exists to take a blood sample and separate cancer DNA from normal DNA. And this cancer DNA could be from any population of cancer cells existing in that body. In this way, we're truly able to hone in on these cancer cells in real time. As novel treatments continue to develop based on these findings, hopefully we'll be able to eradicate the mutations as they evolve. I find this simply amazing. 20 years ago, this was science fiction, and now it's actually reality. In summary, what's old? Although chemotherapy still has its place in triple-negative breast cancer, it's being phased out in favor of more effective targeted therapies. What's new? Immunotherapy, most effective when used in the first line. ADCs, further trials ongoing to evaluate its efficacy in early lines of therapy, and PARP inhibitors, targeted therapy for patients with BRCA1 or 2 mutations, now moving also into the curative setting. And what's next? Individualized genomic targeting via next-generation sequencing. I thank you for your attention, and I'm willing to take any questions.